Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussions surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations.
Hey, Teresa, how are you doing today?
I'm good, thank you. I'm just looking out at the raindrops that are starting to fall, but I miss the summertime already.
Yes. We'll send the rain my way. We're still a little bit dry here. So
Okay, I'll send it back your way.
Well, I have a case I can present to you here. So this particular case that I've got is a Medicare Advantage case, and it had a 2-midnight length of stay. And this was a 60-year-old male who had a diagnosis of a tonsillar carcinoma and underwent a radical tonsillectomy and a lymph node dissection, as well as a ligation of the right external carotid. And they had a 3-day length of stay with that original stay. And they during that original hospital stay, they had some pain control issues, swallowing issues, all very normal issues. But on day of discharge, the patient was tolerating oral intake, being managed on oral pain meds, so went home. So this patient, though, came back to us 2 days later after discharge, complaining of throat swelling and difficulty swallowing. And they said the first day they went home, they actually did really well, no problems. And it was just after that, they started to have issues, really couldn't get much down. And so they called their ENT surgeon and they said, you better come in and get checked out. And so in the emergency room, they felt the patient was dehydrated. They gave the patient some IV Decadron, a liter of IV fluids and some IV. So then on hospital day 2, the patient was taking a little bit of oral, but only about 500 cc's for that whole day. ENT had seen the patient. And one of the things we have that we've gotten our consultants to use in their note is a dot phrase. And it says, and there is patient medically ready for discharge from your standpoint today. What are the, remaining issues? What are the follow-up plans? But it's got a lot of nice pieces in there. And this surgeon did a great job of nicely documenting they are not ready to go today. And why? Because the patient's intake is still not adequate and they need to continue on IV fluid. So it was all there, very nicely spelled out. The patient, in terms of their pain med needs, they've been switched to an oral oxycodone. So they were not needing the IV, but it had been switched to oral, and that was not something they had at home. Continued on some oral steroids and oral Neuron to try to manage that pain. And so then we, surprise, surprise, we got a denial from our Medicare Advantage payer. So I guess, what are you thinking at this point in time in terms of how you would manage it? Would you take the time to do that peer-to-peer? Would you say, that not a lot was going on that second day and I'd probably just refill it?
I'm a little bit slanted and biased here based on my clinical practice, which is ICU work, because as soon as I hear somebody has come back after that type of surgery and they're having trouble swallowing, my next thought is, are they going to protect their airway? And I didn't hear you say anything that, that there was a problem necessarily there, but you have a patient who went home and they came back 2 days later with worsening of their symptoms, most likely because of swelling. And that's evidenced by the fact that the doctors gave IV Decadron in an attempt to decrease the swelling. And you also have clinical signs with dry mucous membranes, et cetera, that the patient's dry, so they haven't been getting PO that they need. I think I would be very concerned. And would you need to exceed what would be considered observation level of care? I think the fact that you're continuing steroids and that you're continuing to monitor this patient's intake because it's necessary, and you've exceeded 2 midnights, that you have met the criteria for medical necessity. I would consider it to be on the weaker side if I were going to argue it in a peer-to-peer, but I would definitely argue the peer-to-peer because in my mind, medical necessity has been met. And I don't know how you guys do this with your particular payers, but most of our payers at this point in time would say, if we do call it inpatient, would you combine the cases? And I might be getting ahead of myself here to say that I probably would have combined the cases because I think the second admission here is very much related to the first admission, not necessarily because of anything that we did incorrectly, but just because of the course of the process that goes along with this type of a surgical intervention on that cancer. So what'd you do, Rebecca?
Well, we did go ahead and, because I think the medical necessity was legit. It wasn't a social, they weren't staying there just because. I think it was, we had, a very logical, sound medical reason for it. And it was documented too. Because sometimes, you and I can maybe see that medical rationale, but there's nothing to chart. But we actually had, nice documentation of why the patient needed to stay. And I still feel strongly, especially if it is documented there and it's not just a canned phrase, who are we to really second guess that clinician, and the payers really should not be doing that either. And I think this was legit. I think there was reason to also have, I didn't play it up, but certainly concern, for this gentleman to have airway issues and keeping him in that monitored setting was also important. Maybe you'd have to escalate back to some IV steroids. Who knows? Had a lot of potential for things to happen. So we did do the peer-to-peer. Unfortunately, the payer would not overturn. They were just, and it's one of the medical directors we oftentimes will have issues on that they have other criteria they want to see. It doesn't really matter if they stay past that 2 midnights. They're not necessarily, this particular medical director is just not, really following the 2 midnight rule. And so it really has to check a lot of boxes. It probably would have needed hypoxia, or they would have wanted something else tangible before they would have given it to us, unfortunately. But we are going to request a written appeal on this one. We discussed it with our, my physician that did the peer-to-peer, and, we're definitely both on the same page about that going off for their appeal.
I absolutely agree with you, Rebecca. I would have put it in for appeal too. I think, again, I said to you, I thought a weak case, not weak in that I don't think it had medical necessity, weak in that I can almost hear your payer saying all the things that they said. Yeah. And it's ridiculous. This is not somebody you would send home after 1 midnight when you're concerned about their nutritional intake, possibility of airway compromise, possibility of becoming dehydrated and having worse problems. And kudos to you guys for creating a dot phrase for your surgeons, because as we well know, especially those of us who work with surgeons on a daily basis, their minds are often occupied in other locations than documenting into the medical record. So having them had that given to you because they were involved as you were in making sure the medical record reflects the medical necessity for the stay, that's wonderful. That's really good.
Yeah. And the other thing that we've been doing with that, it wasn't really designed so much for my purposes, but it does help me, an added benefit. Our original design for that was really to help kind of care coordination amongst the team, to get our, to really help our hospitals, especially when you got a big, hospital and you've got you can have 5 or more consultants for every patient. Our hospitals were struggling to wrangle their consultants, know what the plan was, and they were always waiting on the consultants, waiting. And we saw that was really adding to our care delays. So we actually implemented this to help with length of stay interventions, to just have everyone's thoughts around like, what is our discharge plan and what do we still need to do from each service line before they can go? And if they're done, it's really clear. And what is that follow-up plan? Having it in writing so that we have reduced errors, reduced readmissions because we didn't get the meds right based on what the service wanted. So it's been a good, seems like a little thing, but it's really had some nice impact for us. So.
Yeah. You're getting a lot of bang for your buck, and that's a good, thank you for sharing that with us. So,
yeah.
The Association of Physician Leadership in Care Management, or APPLECOM, was created to provide support and education for physicians in this field. APPLECOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more. Let's continue with our next case.
Well, I was going to take us to our second case then for today. In the last session we had, I presented a case of an eye injury that ended up being denied, that I thought was incredible for being denied, but the appeal is ongoing for that. So I want to bring you a case today of a 65-year-old female, and she has a history of refractory epilepsy, partial complex. And she had been lost to follow-up. About 10 years ago, she was seen in our epileptology clinic and followed by our epileptologists for the possibility of having surgical intervention to remove her seizure focus so that she could become less dependent on anti-epileptics. And the problem was she just was not interested at all in pursuing that. And so she was lost to follow-up for 10 years. So she came back into clinic, and we were admitting her, and she was a direct admission, not through our emergency department, for a surgical workup for her refractory epilepsy, because there was evidence in the past of a unilateral left temporal location for this seizure focus that she had. So she came in and she actually stayed for a total of 5 days, 4 midnights. The first night that she came in in the evening, and she was placed on long-term video and EEG monitoring. And included in that, we have telemetry monitoring, because we've had the case in the past where patients will go into status or have a seizure, become bradycardic, and arrest. So we always keep them on the telemetry monitoring too as part of that. So we were looking for any kind of bradycardia, arrhythmias, or anything that might have happened had she had a seizure. Of course, we had our seizure precautions in place, and the camera was focused on her for noticing any events that she had. And that was on the 29th. So on the 30th, the second hospital day, we decreased her zonisamide, which is one of her 3 anti-epileptics, to half, down to 100 milligrams twice a day. And we also dropped her levetiracetam completely off of her regimen. So now she's down to 1.5 of our anti-epileptic drugs. So over that day into the next day, which would have been over the second hospital day, onto the third calendar day, she had a single event that was caught on the video monitoring, and a button was pushed, and the epileptologist reviewed it, but it did not have an EEG seizure correlate to the event. And it really wasn't a typical spell. It was just concerning for her. So it really couldn't be counted as seizure activity on that third calendar day. She then had her zonisamide held. So we're off of our levetiracetam, we're off of our zonisamide, and her clobazam, which was her third anti-epileptic, was taken to half, down to 5 milligrams. So now we have her only on half of one of her 3 anti-epileptics. We're moving into our fourth calendar day, and overnight from the third into the fourth calendar day, that third midnight, she had 4 events. and all of them were coming from the left temporal lobe. They were identified as seizure, and she had her typical seminology that she has with them, and they were all push-button events. So seeing that she was actually having 4 events there in a short period of time, we were concerned, and we began adding back immediately her anti-epileptics. And we kept them on them for a 24-hour period, and she stayed over that 4th midnight into her 5th calendar day to be certain that she wasn't going to kindle and end up having a lot more events over that next 24-hour period. So I bring this case to you because we get these frequently because we have a large neurology section in epileptology, and we also have a seizure surgery program. We bring these patients in, and if we don't take them off of their medications, then that's one thing. But we were actively and very vigorously down this woman's antiepileptics. And the real fear here, and I have watched it happen many a time, is that the patient will get to the point where they go into status epilepticus. It's a big concern for these patients. But the payer denied. They denied the whole hospital stay, all 5 days, all 4 midnights, saying this was an observation process. What do you think, Rebecca?
Yeah, I mean, I think these video EEG cases, it's been going on for a long time, but they can be tough. They often have those longer length of stays, and you do tend to see a lot of denials that can be hard to overturn. And I think because a lot of times you end up watching them and you don't have anything happen, and those in general, like even if it's a 5-day stay and nothing happens, I've really found that you typically cannot get those overturned. I do find if they have an actual event and you're changing meds, that it typically is enough to, be able to solidify that inpatient. And, not that they don't appeal. Sometimes I feel like it's just kind of a knee jerk. It's a V. Let's just deny and then make you prove to us that, it was worth inpatient. Again, I don't know when they get the case, what they see, because I know some of our payers will say, well, we review it at this point and then it may stay later and we deny later, but we only review it based on that, whatever little amount of information we had. So I definitely would have gone after that. I think this one to me has some legitimate merit to be able to be one. So I don't know, I'm assuming you took this one to peer-to-peer.
Yeah, we took it to peer-to-peer, but I, like you, have watched so many of these long-term monitoring cases get denied and remain denied that I'm kind of a little bit biased now to thinking that they're never going to get paid as an inpatient. But on this one, I could make the argument adequately that we had somebody who went from having no seizures, having only a half of 3 different antiepileptics left in their system, were starting to have multiple seizures, needed monitoring, had a real risk of status epilepticus. And we got answers because we actually had events. And I think you're right. I think that helps to drive this. Anytime we're changing meds, though, I will talk to the other physician advisors, and my leaning, because I'm involved in the neurologic world, is to call them inpatient because, I guess, I have seen patients have really adverse outcomes in their surgical evaluations when their antiepileptics have been held and they go into status epilepticus. It can be quite a harrowing experience for the patient, their families, and for some long-term consequences too. So we did this one in peer-to-peer, and the medical director from the payer, agreed that this should be overturned denial. So we managed to get that one back, even though I lost that eye case from last session we had.
Now, do you find, though, because you are a neurologist and, I'm a hospitalist, so, we deal and as a physician advisor, deal with every sort of, subspecialty, including OB and all the surgical subspecialties. Do you find that you do have that advantage compared to your other physician advisors on these complicated neuro cases? And do you find that within your own group that have you gotten to the point where you subspecialize in certain kinds of denials because the outcomes are better? Is that something you guys have looked at or?
Yeah, we don't actually tailor a certain case to a certain PA, although we could, because we're a big academic medical center. Yeah. You're a big program. So, for instance, we have a really wonderful pediatric otolaryngologist. So we have a very subspecialized person who I will actually but I know this, we know this about each other. And we'll often reach out to one another through our team's conversations, or actually just paging or calling our colleagues and saying, this is what I'm seeing. What can you tell me? Because sometimes I'll call up the pediatric ENT and ask her, or I'll be in a situation where I'll ask her, what do you think when you see this kind of a report on the airway evaluation? What are the things that you're concerned about, and how do I make the best argument for the medical necessity here? And my colleagues do the same for me, because I'll review the scans for them and take a look and say, obviously there's a doctor who's actually seeing the patient and taking care of the patient, but we all can help each other because we have these subspecialty capabilities. Like, I'll call one of the hospitalists to say, hey, you know what? What's the current thinking about these numbers in this pancreatitis patient and their electrolyte disturbance and what we would do next? And they can give me the most up-to-date information, because we're all practicing too. So I really love that about being able to do that. But the nice thing about that I like about peer-to-peer too is that hopefully, and most of the time we get reasonable medical directors from our payers, is that we can have those physician conversations. And even sometimes they'll say something that will drive me to say, oh, I hadn't even thought about it that way. They're actually helping my case with this. But that's because of the relationship we've developed, understanding that we're trying to look at these cases as completely we can.
Yeah, no, I definitely have found it helpful over the years. Like, we have a little bit of diversity of medical specialties within our PA group, but if we don't have it and it's something, a more complicated case, like that ENT case, if there was more going on and I was like, what about the airway? Or, I do think it's helpful to be able to talk to your subspecialist, and then in that peer-to-peer say, I talked to the ENT doctor and this is what they saw. This is what they were worried about. These are the risks. Or, some of the cancer cases too, those can get really tricky, just areas where I'm definitely not the expert. And so I think just letting that other paramedical director know that this is the information you got, because likely they're probably coming from more of a generalist background as well. And they may not know what they don't know either. And so I think that can, help with these more complicated cases that a generalist would not see too often. So.
Agree. Well, this has been wonderful, Rebecca. I've enjoyed the two cases, and as always, hope our listeners found some pearls of wisdom in them.
Yes, agree. Yes. Take care. Thank you again for sharing.
Thank you. Have a good evening. Bye-bye.
Bye.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Sabir, Singh, and Jacobs for sharing these interesting cases in these episodes. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.